Good day, budding epidemiologists. Today's topic is LOUICS, the law of unintended consequences in public health. Let's start with alcohol regulation. After many years of organization and lobbying, primarily by the Women's Temperance Union, led by both suffragettes as well as religious organizations, the U.S. Constitution was changed on January 19, 1920 to outlaw the production, sale, and use of alcohol, thus signaling the start of 13 years of prohibition. The actual goal wasn't so much the evils of alcohol per se, but to keep men at home with their families, to decrease alcoholism, decrease liver disease, improve the family life, improve property values by the closing of salons, otherwise known as bars or taverns, to somehow increase revenue to clothing, restaurant, and entertainment industries, as well as to decrease crime, because as we know, when alcohol increases, crime tends to increase as well. What actually happened? There was a 30% decrease in the consumption of alcohol and death from liver disease, so primarily cirrhosis of the liver, which was primarily caused by alcoholism. It is noteworthy that this trend did start several years prior to the ratification. Unfortunately, there was a huge increase in crime, and in some ways the origin of organized crime, gang warfare, and homicide. There was actually a decrease in revenue to clothing, restaurant, and entertainment industries. One reason because of the huge loss of sales tax revenue by closing taverns and bars and salons and losing all the sales tax related to the sale of alcohol. This resulted in thousands of unemployed people from the alcohol industry. And instead of having legal bars and salons and taverns in certain areas that were regulated by zoning boards, you then had speakeasies or illegal bars and taverns in various households around through any neighborhood, and this actually resulted in a decrease in housing values. Law of unintended consequences. So looking a little more in detail, here is the death rates of cirrhosis of the liver, and this is showing the United States, France, Canada, England, and Wales. And if you look between 1910 and 1920, you can see that for the data that we have, France, the US, and Canada, there was already decreases in cirrhosis of the liver death rates. During the Prohibition time in the United States, it's a relatively flat death rate, decreases in England and Wales, but increasing in Canada and France. So pretty hard to show a cause and effect of the 18th Amendment on decreasing the death rates of cirrhosis. That's from Terrace, published in 1967. Prohibition led to a huge unregulated illegal industry, much like what the same problems we have with other drugs in today's society. A black market alcohol safety and quality varied. So you could end up, because there was no regulation of alcohol and no inspections, that was sold was all illegal, and therefore it could be mixed with other things. Mostly methanol or moonshine, and tainted liquor caused an estimated 1,000 deaths per year during Prohibition. We don't have a estimate of deaths for that prior. I think it's safe to assume that it was much lower, but we don't have that data, so we can't say. Due to the black market, increased crime, organized crime, and all the other unintended consequences, in 1913 the 18th Amendment was repealed, making alcohol sales legal again in the United States. This is the murder rate in the US, and I've put in the arrows showing the start and end of Prohibition, and you can see again, can't read a total cause and effect here because if you notice, there was a significant increase between 1905 and 1920. So the trend simply continues during Prohibition. If one of the goals was to reduce violent crime, Prohibition certainly did not do that. Whether it actually caused a huge increase is debatable. Certainly gang-related and organized crime hits, I think most people would agree, increase significantly. But do notice that upon the repeal of Prohibition, the murder rate does sharply decline from over 9 per 100,000 to below 6 per 100,000. Certainly not getting back down to the rates in 1900, but perhaps there was a positive effect of ending Prohibition, at least on the murder rate. And finally, if one of the goals of Prohibition was to improve family life, and by that we're defining it as lower divorce rates, men at home rather than out at the bars, and less, hopefully less domestic abuse due to less alcohol, we do see that there was no change from 1920 to 1930 in the divorce rate. Interestingly, the marriage rate went down significantly at the early part of the Depression, and that resulted also in a slightly decreased rate of divorce as well. If you have fewer marriages, then you would expect at some point fewer divorces. Though not coincidentally at the same time, I would think you'd expect a slight delay of anywhere from 1 to 5 years at least. All interesting numbers and data. A similar action occurs with gun control, at least in the United States. Now, it's hard to draw general conclusions within other countries, though. If we look at the United States, let's start with the age standardized firearm homicide rate. This excludes suicides. This is homicide. And number 2 here, we've got the United States at 6.3 per 100,000 for males and 1.0 per 100,000 for female. I am going to assume that by female and male we are talking about the one who perpetrated the homicide, not the victim. So the US at 6.3 in males compared to our neighbor Canada of 0.8. We see roughly a 8 times higher rate of firearm homicide in the United States compared to Canada. Now, obviously, the US and Canada are very different countries, even though we share a border, share some of the same climates, at least along the northern US and southern Canada. By far, the majority of Canada's population is along the southern border. Canada is much more similar to European countries in that they have had some types of gun control since 1969. Specifically, they have prohibited handguns with barrels less than 100 millimeters long. They've banned sawed-off shotguns or rifles, and they have banned any automatic firearm. I could not find exact dates when these particular prohibitions went into effect regarding firearms. It was an incremental change in gun regulation in Canada. Germany has the reputation of being the most, or one of the most restricted countries in the world regarding the ability to obtain legally a gun and or use one. Their regulations significantly began in 1972, and it strongly limits who can even get a gun legally. The law says only those with a creditable need, but it turns out the way that's enforced is it is very strict. There are not many people with a creditable need for guns, and certainly for handguns. And Germany has banned all automatic weapons since the early 70s. Now, can we say that Germany's and Canada's regulations on guns has led to their significantly lower rates of homicide by firearm compared to the United States? I think it's safe to say in part, but again, these are very different countries. The United States has more large cities, a larger poverty rate, a larger drug problem, crime rates in general, a wider variability of people of different socioeconomic statuses. So if we were to control for all those, we might not find quite as big a difference in firearm homicide rates between the countries. Nonetheless, would we find an 8 times rate? Probably not. It is important to note that because cultures are different between countries, one of the reasons the United States has not implemented gun control is because in a democratic culture, it has not been allowed to occur by voters. So here are a list of U.S. attempts at gun restrictions. I purposely left the first 200 years basically blank. There were different attempts and small regulations passed, but to emphasize the lack thereof, I've left it blank. And then most notably, right after the Sandy Hook Elementary School massacre by a mentally ill person who had access to several automatic weapons, in 2013, the U.S. Congress voted down proposals made by President Obama and Democrats in the U.S. Congress. Such provisions as, and this is the one I find most unbelievable, that background checks for gun purchase, which were designed to prevent criminals and mentally ill persons from purchasing guns, was voted down by the U.S. Congress. Another one, which I can at least see the Second Amendment rights folks getting around, is that it would limit the number of rounds an automatic weapon can shoot at one time, in other words, the length of the magazine, and to ban military-style assault weapons. All of these were rejected by the U.S. Congress. And most point to the successful lobbying by the National Rifle Association, which jumps up extremely quickly and harshly any time any gun legislation is brought forth nationally. Here is another example, and I guess I've strayed way off the topic here, and I'm certainly showing my bias. From both a public health standpoint as well as my own political standpoints, I do not feel that handguns are necessary to defend one's home. I do not feel that military-style assault weapons are needed to go hunting for deer. I have no problem at all with people hunting and taking animals for their own meat. But if the main reason that the Second Amendment proponents say is that they have the right to defend their own property, you can sure defend yourself a lot better with a couple good shotguns than you can with a .38 caliber handgun, which really the only purpose of that weapon is to carry it concealed and to kill other humans. But as an example of how silly things have gotten is that the lobbyists have successfully removed any federal spending towards the research of gun violence in the United States. So not only is it not permitted to restrict guns in the U.S., we're not even allowed to study with federal funds what the influence, what the epidemiology of gun violence is. So what happens after calls go up for new gun restrictions? Well, actually, Obama has been quoted as being the best gun salesperson in the country in history, because each time Obama has spoken strongly about introducing new gun registration or providing executive orders to limit gun sales, then the sales of guns jump dramatically because people are afraid they're going to lose that right, so they immediately go out and buy a bunch of guns, even though they don't know if they really need them or not. Doggone, I'm going to have them just in case they get outlawed later. Let's talk about another more uncontroversial public health area in terms of the law of unintended consequences, and that is polio, and this is covered in a little more detail during our lecture on vaccines using the case study of polio vaccination. Polio was actually a very common condition prior to the around 1910s or so. It was rare and mild and usually acquired during infancy as a waterborne virus, and this would lead to a lifelong immunity to polio. It was often kept in check by the immunoglobulins transferred from maternal milk during breastfeeding. It was the advent of sewage treatment, actually indoor plumbing and sewage treatment to carry waste long way away from drinking water sources, which of course was probably the greatest public health milestone in history. But the unintended consequences was that it did remove most of the naturally occurring polio viruses and therefore the infant exposures. So then we had kids growing up later in life and even adults, most famously Franklin Delano Roosevelt, who did not get the mild cases as infants and then were susceptible, so that during epidemics of poliovirus, especially in the summers when sewage was more likely to be cultured and in the warm weather and have epidemics, then ingesting the polluted water one way or the other would lead to full-blown polio virus and encephalitis and could lead to paralysis, partial paralysis, and even death. It was mistakenly thought of as exposure in swimming pools or lakes or other places that people would swim, because in the summer you swim. Again, this was a confounder because in the warm weather, when there just happens to be more polio and people are swimming more often, they thought that maybe it was swimming that would cause the increases in polio, but it was ingested through water sources. Another public health fact, dietary fat. Well, the fact is we know that high blood cholesterol and high LDL, low-density lipoproteins, is associated with stroke, heart disease, and some cancers. So it makes sense that we would decrease the fat in our diets. So especially animal fats should be decreased. The result was that low-fat foods were provided as a supposedly healthy alternative for multitudes of people, but those are actually higher in simple carbohydrates, especially refined sugar. Some are also high in salt. So the unintended consequence here is we actually had increased rates of obesity and diabetes, heart disease, and stroke because people ate so much more simple carbohydrates, which actually have higher density of calories per gram than fats. So unfortunately, eating a low-fat diet is not necessarily a good thing. Certainly eating a diet that is low in triglycerides, low in cholesterol, and low in um, saturated fats is certainly a bad thing. So you do want to go to a more plant-based diet, but not necessarily low in fat. You want to increase your monosaturated fats and your polyunsaturated fats. So stay away from butter, but definitely use olive oil or grapeseed oil, avocados, nuts, walnuts, etc. that have high amounts of what we call the good fat and low amounts of the bad fat. Now, it is important to note that during this increase in obesity and its consequences was also a concomitant increase in the, quote, sedentary lifestyle as we went to more office-based and service-based economies rather than agricultural and industrial manufacturing jobs that require more physical activity. Now some policy changes that resulted in unintentional consequences. There was the Medicaid Disproportionate Share Hospital Payment Program. This occurred in the 1980s during the Reagan administration and its Omnibus Reconciliation Act for budgetary reasons. There was an assumption that hospitals which serve large volumes of Medicaid patients also serve large volumes of uninsured or unable to pay patients. Certainly makes sense when you think of some of our large public hospitals, often located in the center of inner cities, or other small rural hospitals with large numbers of Medicaid patients, or as well as folks that come in who are uninsured, and if someone comes into the emergency room, they have to be treated if they are an emergency patient. And oftentimes a hospital that's a for-profit or a private hospital that doesn't necessarily accept Medicaid or uninsured people, they have to make sure that the patient is stable, but then they can legally transfer them to one of these other hospitals that accepts Medicaid. So there was this assumption that the hospitals which served large volumes of Medicaid patients also served large volumes of poor uninsured patients as well. So the government increased Medicaid payment rates just in general across the board because they figured, well, hospitals that take a lot more Medicaid patients will receive higher reimbursement rates because they have more Medicaid patients. And this was assumed to provide a buffer for them to also take care of the non-paying patients. The results, well, as soon as an insurance company provides a higher reimbursement rate, well, more people are willing to participate. So more hospitals that normally wouldn't accept uninsured or Medicaid patients in the first place started accepting and started competing for these patients. But they certainly did not try to attract the uninsured or impoverished patients. So the unintended consequence was the hospitals with the highest numbers of uninsured and non-paying patients actually lost some of the Medicaid patients that now had the higher reimbursement rate. And the hospitals that weren't going to accept those in the first place were getting a piece of that pie that was not intended for them. Before the passage of this bill, the public and Medicaid serving hospitals actually lobbied against it, saying we don't need this, this is actually going to hurt us, and they were right. And I believe that policy is still in place. Here's a good one. That is the S-chip, which stands for the State Children's Health Insurance Plan, I believe, or program. And this is actually a great insurance program to subsidize health insurance for children. The goal is that to get all children covered with health insurance one way or the other. If they don't qualify for Medicaid, if the family makes too much money to qualify for Medicaid, but they're either self-employed and either cannot or choose not to participate in private health insurances, because if you're self-employed in a very small business, the premiums are extremely high. So that's why many small businesses do not provide their workers with health insurance benefits. You need large numbers of people to be able to have a larger pool to pay into in order to get private health insurance. So children of working low-income parents who do not qualify for Medicare but cannot afford health insurance or choose not to because of the high rates should at least get their kids' health insurance. So this government-sponsored program, S-CHIP, provided a very reasonable alternative to get all kids on. The result was that working parents of even large businesses could then compare their employer-based family insurance to the S-CHIP's rates and elect to purchase S-CHIP for their children, and then either go without adult coverage or family coverage, or purchase just single or dual coverage through their employer. So the consequence was there was a great increase in child health insurance coverage. This is good. But some well-off parents, including myself, moved their children off their employer-sponsored plan and paid the income scale fee to enroll their children in S-CHIP. Let me explain this a little bit. It turns out, unlike Medicaid, which has a cap on how much money one can make, S-CHIP did not have a cap. Anybody could enroll their child onto S-CHIP. Now initially, that was not true. Before it was S-CHIP, it was just called CHIP, and that there was income limits. It was basically worked just like Medicaid, only it was a higher income limit so that you could get your children on even if you yourself couldn't get any health insurance. But it was later changed basically on a sliding scale up to a full price essentially that anybody could enroll their children. So my employer offers healthcare insurance, which has always been a relatively generous benefit by the employer for a single individual employee, but all of the family plans have always been quite expensive. Now, my younger son, which I may or may not have shared with you in previous lectures, is on the autism spectrum with comorbid attention deficit and some other behavioral issues. And the medications that allow him to function most of the time at home and just about all the time at school, some of these are name brand and only available as name brand. And between the 4 or 5 that he has to take, I don't know today's tally, but it's quite a few. The monthly bills for the medications alone could run well over $1,000. Through my employer's family health options, at least one of the most important medications was not covered, and they required him to use a different medication which was already shown to be not nearly as effective. Thus, when we had the opportunity to enroll him, and we enrolled our other son as well, onto S-CHIP, we did the cost comparison and found that our premium payments for S-CHIP for both kids was much lower than what our out-of-pocket expenses would have been just for the medications for our younger son. So it's a pretty no-brainer from our standpoint. I could either work full-time and have 30% of my income going towards my kids' insurance and medications, or I could enroll on SCHIP and um, have a more reasonable, I don't know, 15% of my income going towards all health insurance from all my entire family. So that's what we did, much to President George W. Bush's consternation, because he actually pointed out people like me are not who the SCHIP was intended for. The SCHIP was intended for people that had no access to an employer-sponsored health insurance plan or were quite well off and could afford their own health insurance plans. But in actuality, the employer-sponsored health plan was pretty much inadequate and too expensive for one patient with special needs. So that's what we have done, and it has been quite successful for us, and I thank the United States government and SCHIP for providing that option for me. So now I have just my wife and I get our health insurance through my employer, which is still pretty expensive even for two people, but the big difference is which plans cover which medications. And you see this time and time again with the aged patients who look at the different Medicare plans where they have to know what medications they're taking primarily and how to decide which health plan to enroll in. There are what are called vision insurance plans that are carve-outs among people's major medical insurances. Some common ones in the United States are March Vision, iMed, Davis Vision, Vision Service Plan. I believe there's something called Optum or something like that out there as well, and I'm sure there are many, many others. And what these do is they cover basically an routine eye exam and glasses and possibly contact lenses, depending on the plan that is chosen by the major medical insurance or the employer, whoever decides who to get that vision plan rider on. And generally, these services are only covered every year or every 2 years. Now, a no-split plan is one in which the patient must select and order their glasses or decide on contact lens services and materials on the same day as their exam, their routine exam, that is. Now, this leads to a problem. First of all, many patients are dilated when they finish their exam, and then they have to go down and pick out glasses when they're all blurred up. That's not fun. Another problem is many patients have borderline conditions. Take the 8-year-old with maybe very mild myopia, 20/25 vision. They don't really need glasses. But if their plan only covers an exam every 2 years, we have to inform the patient of that fact, or they may know that already. And then it could be that the patient asks for a glasses prescription even when they don't need it. Because if they don't get it now, they have to wait sometimes 2 years. By that time, the patient might be significantly myopic and don't have any help at all. Or they have to come in 1 year and pay for an exam and pay for glasses, which they obviously don't want to do. So the result is that these no-split vision plans, the patients will be getting glasses that day because it's covered that day, not necessarily because they need them or may not even use them. And it might not just be glasses. It might be an entire contact lens fitting exam and training and follow-up for contact lenses. Another problem with some vision plans is that they require an exam, a routine exam, with a whole database of required tests and procedures in order for the patient to receive a glasses prescription and get their glasses covered. Now, For patients that are in our office for medical reasons, such as diabetes or cataracts or glaucoma, but also have the vision plan carve-out, we can't provide a refraction only and charge for it and then give them a prescription to use their benefit. We have to provide the quote routine exam. So essentially, maybe they saw the doctor on Tuesday for their glaucoma check or full glaucoma evaluation or their annual diabetic eye exam, which is billed under their medical insurance, as it should be. But they want a glasses prescription. Well, they have to come back on Wednesday and get a cursory exam, sometimes by a different doctor, who's now responsible for the eye health as well, might find something different or might disagree with the first doctor's exam. See the quagmire that happens here? As well as the fact that we are doing unnecessary tests. We are duplicating slit lamp exams, neuro-ophthalmologic tests, pressure checks, and fundus exams unnecessarily. Very hard to understand from both a patient perspective, a cost-effectiveness perspective, and a general practice efficiency perspective. Example, antibiotic overuse. Of course, you're probably quite familiar that antibiotics are used very widespread for farm animals, usually at low doses. They're also used too much by people that have a common cold or other viral infection because they believe that they need an antibiotic and an antibiotic is going to make them better. And in some cases, the doctors or veterinarians justify the use of antibiotics because it prevents secondary bacterial infections, and it does indeed increase farm production. But the result, the use of broad-spectrum antibiotics at sub-threshold dose will, of course, lead to resistant bacterial strains, which have become more and more common with time, and effective antibiotics become less and less sought after. DDT. This pesticide is extremely effective as a mosquito insecticide. It is also extremely effective for many different insects, some of which are helpful for the environment. And mosquitoes, of course, do have their place in the environment, even though myself personally, I could be quite happy with a world without mosquitoes. It was used throughout the early and mid-20th century, and at least in the U.S., and is still used in some countries around the world. And the result was that it was very successful in removing malaria from many areas, including the entire mainland United States. There have not been any locally sourced malaria incidences in the mainland U.S. in a long time, although now we are getting Zika. It helped prevent many tropical diseases, especially to susceptible soldiers in the 20th century wars. Also used extensively for agriculture. So the unintended consequences were that DDT is toxic not just to insects but to humans and to other animals. It also goes up the food chain, and it led to the near extinction of the bald eagle and other environmental disasters. Some will argue that in low doses it is effective enough to prevent malaria, but not so high that it causes these other consequences, but those things are very difficult to show long-term safety for, so it's very reluctantly used in most places. Of course, we have various drug problems that showed up long after the initial phase 1 or phase 2 clinical trials that resulted in unintended consequences, such as thalidomide, which was used widely in Europe and was helpful for combating morning sickness or gestational vomiting and illnesses that can sometimes make a woman have an unhealthy pregnancy. So again, it was a good idea. Unfortunately, it was found to be associated with significant birth defects, such as children being born without the right number of limbs or the right length of limbs. Vioxx, which is a great non-steroidal anti-inflammatory for pain, arthritis, and other conditions. Later, after widespread use, was found to have an increased rate of heart disease and even deaths. Accutane, a fairly common but toxic medication used to combat teenage acne. I don't remember the exact side effects, might have been neurotoxicity, but it is a pretty toxic drug, so again, first it got a black box warning, and then it was actually taken off the market as well. Fen-Phen was a dietary, a diet pill to help people lose weight. Again, great intentions, but the side effects and health risks turned out to be much too high. DES is an estradiol compound. I can't remember what exactly it was prescribed for. It may have been similar to a hormone replacement supplement. But anyway, it ended up having very high rates of toxicity and health impacts that were quite dangerous. So that's just to name a few. And finally, to end about the law of unintended consequences, a 2009 swine flu outbreak in Egypt prompted Egypt to slaughter all pigs and ban garbage-fed pigs in the country, especially if most of your population is Muslim. This would not cause a really big problem for the majority of the population, but there were non-Muslims in Egypt that would like to eat pigs, and they would have pigs even within the cities that would eat and feed on garbage. Now, once all the pigs were killed and then banned from having new ones, it resulted in an increase in uneaten trash, which swamped the streets of Cairo and other areas. And it turned out that the garbage disposal companies or their workers were underpaid to start with. And so the result was huge increases in trash, especially food wastes from households and restaurants in a very warm climate. You can imagine what this led to. The unintended consequences was an increase in trash-related diseases from the rotting food, the smell, fleas, the vermin, all the different insects and other animals that came in to replace what used to be the pigs. So your garbage will be collected when the pigs fly. Seems like an appropriate place to end on some of these kind of hard to believe but actual happenings in the history of public health and its unintended consequences.